Welcome back to the program. We've been discussing efforts to stabilize Ontario's health care system, and one such effort was announced by the Ford government. That includes increasing the number of publicly funded surgeries performed at private clinics. In other words, finding more supply through the private system without eliminating a single payer. Dr. Sheikh, broad strokes first. Were you pleased to see this announcement? Is this the right direction?
So I was not pleased to see this announcement. I think it's important that we publicly fund these surgeries, which is what the government has committed to. But it is also committed to expanding private for-pay delivery, or private for-profit delivery. And it's important to make that distinction about who's paying and who's delivering the care. There is no reason why we can't provide high-quality care and high-volume care to reduce the surgical backlog without lining the pockets of shareholders. We have great examples in this province of private, not-for-profit delivered care. It does exactly that. High volume cataract surgeries, high volume procedures. And we know that we're gonna end up spending more to get the same results or even worse results. And we're gonna line the pockets of shareholders with public dollars at the same time.
Dr. Gorfinkel, would you agree?
To some degree, I absolutely do. But on the other hand, the system needs some give. There has to be some give in all of this. One thing I know for sure, the siloed care we now have is not working. So breaking down the silos, as Alberta has done, and as, in terms of having one electronic health record for the province, is a major step in the right direction. Because we're simply not making the optimal use of the services we now have. And that's a serious problem. Is this problem going to be solved by Maple Care, by what it does in terms of virtual care? I have grave concerns about the quality of care that can be delivered on a computer screen. And that's because if I lose my physical examination, the human touch, the human interaction, I've lost a tremendous amount in medicine. I'm more likely to order labs. I'm more likely to order x-rays. And of course, all of this has significant downstream effects, as I've had to learn in the pandemic.
Dr. Belchetz, I'll get you to respond to what Dr. Gorfinkel's just said, and maybe also comment on the announcement by the Ford government.
Yeah, so I think we as physicians are trained to make decisions and judgments based on data, not on gut feel. And what we just heard was gut feel. There's lots of data on virtual care. Kaiser Permanente, one of the largest healthcare providers in the world, was doing 50% of their visits virtually even before the pandemic. So they were doing millions. They are 10 million patients in that. They were doing millions of visits per year virtually long before we ever hit the pandemic. And they have tons of data to show that the accuracy of diagnosis, the outcomes from those visits were just as good as the in-person visits. And nobody's suggesting that every visit should be done virtually, but it's very clear that a certain percentage of visits do not require a hands-on physical examination for accurate diagnosis. And there's no reason to force those people into a clinic to travel across town, sit in a waiting room, et cetera, for those visits. So again, were we saying 100% of visits should be virtual? Yes, we are in a bad place to be. But at the right percentage of visits, there is no data to support the claim that was just made.
Whoa,
so that was a very
whoa. No one was suggesting that virtual care is one thing or another. I wasn't suggesting that we should throw out virtual care. What I was suggesting, in my defense, is simply to say that we need to do that with our eyes wide open. And I don't say that there's not a place for virtual care. Of course there is. But I can tell you, we need to be very thoughtful about what that place is and not open that floodgate.
Go ahead, Dr. Belchetz.
Again, I think we're talking about a gut feeling, and I'll wait for the data to come out. I've seen bad medicine practiced in the emergency room. I've seen bad medicine practiced in walk-in clinics. So yes, there is bad medicine practiced in the virtual world. The bigger question is there more bad medicine that we're seeing in the virtual world versus walk-in clinics versus the emergency room. And the data that exists to date doesn't support that. I'm happy to see what it looks like for Canada. But until we have that data, I certainly wouldn't be leaping to conclusions such as what we've heard. The final question is, my response to the Ford government's announcement about increased privatization of delivery of surgeries. I think the bigger question is related to what we were discussing in the past here is, does this increase supply versus take supply out of the existing system? That's the only question we should be asking. So by having extra private providers of surgeries, will we enable or incentivize our existing nurses to give more hours to the OR? Will we get our existing surgeons to give more hours to the OR? et cetera, et cetera, et cetera. Because if this plan allows us to open up excess capacity that didn't exist before, then it's a good plan. If all we're doing is transferring supply that existed in the public system to a private system, no, we're not really accomplishing very much by doing this.
Cathryn, your thoughts?
Well, let's say I'm having a hernia repair done. It's cost X amount of dollars in a public hospital, and then Schuldeis's hernias, how much does it cost there? Say it's $4,000 difference. I don't know. Why aren't we taking that $4,000 and investing it into the current system we have to provide better care and to increase the surgeries there? So to me, we're just lining the pockets of shareholders. And although the health minister said the OHIP card will work, tap, like the grocery store, at the end of the day, the money's coming from the government. Where's the government money come from? They'll increase our provincial tax dollars if they're going to pay it that way. So we're paying for it in the end. Invest in what we have now, fix what's broken before we move on.
André, I'll give you the final word here.
The bottom line is people don't care who provides their care. They want their hips, they want their knees, they want their cataracts, they want their hernia repairs, and they want it delivered promptly and efficiently and safely. And that's what we have to focus on. We can figure out the private-public distinctions. We can regulate better, but that's what we have to focus on. Get people the care that they need, whether it's a primary care physician, surgery, et cetera, and we're just not delivering.
All right, stick around. We'll be right back with more of the Zoomer.